Onc Live Insights is a video editorial program produced by Onc Live. Onc Live Insights features in-depth reports, feature segments, and profiles of leaders in clinical medicine, providing expert perspectives in cancer care and emerging research.
Finally, Erubulin, gets approved by the FDA. It's available. And I put her on Erubulin, the 2 weeks on, 1 week off regimen, which she tolerated fabulously.
For frontline therapy, I often use a regimen with gemcitabine and carboplatin, and thereafter then go on to a clinical trial. Sometimes I'll have a clinical trial that I can use in the frontline setting.
In that particular case, we started with capecitabine-based chemotherapy. Capecitabine is an oral chemotherapy, and it has the virtue of not making your hair fall out and be very transportable and relatively well tolerated.
Hello, I'm Joe Petrozello, Head of Clinical Affairs with OncLive.com. We recently sat down with some of the world's leading experts to gain their insights on the latest clinical advances in cancer care. In this OncLive Insights video editorial series, we will review the evolution of metastatic breast cancer.
So I wanted to start by talking a little bit further, asking you about the evolution and changing treatment landscape in metastatic breast cancer, particularly with the advent of recent approvals and other treatment options in later line settings.
It's interesting. I've been doing this long enough now to actually see this evolution. I think that I started about 20 years ago when we didn't have targeted therapies of any kind. The only real targeted therapy we had was tamoxifen for the estrogen receptor. That was really the only target that we really had therapy for. We had chemotherapies. We had methotrexate, we had cyclophosphamide, we had anthracyclines like adriamycin. But really, that was pretty much it. And I think that in the last 20 years, we've seen aromatase inhibitors really come to the fore, and now are generic. We have drugs like fulvestrant as adjuvant therapy, or actually as metastatic therapy. We have now the targeted agents like trastuzumab, and that's gone on now to pertuzumab, to TDM1, really lapatinib. We have a broad variety of things for HER2-positive breast cancer. In terms of chemotherapeutic agents, we've gone from just simply having anthracyclines to now the taxanes, which are all generic. We have new formulations of taxanes, such as nanoparticle paclitaxel. We have other agents like erubulin that we've never had before, capecitabine, ixabepilone, really new uses of gemcitabine. I think that really there's such a huge number of agents that we can have. And then on top of that now, we're now entering the area of truly targeted agents. We're going to have things like palbociclib, we have everolimus, we really have an enormous amount of things. And I think that our issue is that with such a wealth of choices, it really becomes fairly complicated to figure out the right therapy for the right patient. That's really kind of where we make our money as breast cancer oncologists, is trying to figure out which of these broad variety of therapies, all of which have quite good effects, which ones we really should be applying to a particular patient scenario.
So with advanced breast cancer, like with early stage breast cancer, we really think about three different clinical syndromes or clinical entities. There are hormone receptor positive tumors, which we treat with anti-estrogen therapies for as long as those are effective. There are HER2-driven breast cancers where we use anti-HER2 directed therapies. And then there are so-called triple negative tumors, tumors that lack estrogen receptor and progesterone receptor and lack HER2 expression, hence triple negative. And for those patients, we lean heavily on chemotherapy. And in all these areas, there's a lot of interest in new drug discovery. So one of the things that's changed is we now think about breast cancer really as three different diseases, and we have different treatment programs for each one of those subtypes. The other thing that's changed is that we are now using many, many lines of therapy for all of these patients. We've actually recently published our own experience, and the average patient with breast cancer will get 4 or 5 lines of chemotherapy, and in fact, it's not unusual to see patients who have even 8, 9, or 10 lines of treatment. And so from the patient's point of view, that's good news. It means there are more options. They are going to be candidates for more lines of therapy as we try different approaches in them over time. And from a regulatory point of view, it's been a challenge, of course, because if you can offer 10 lines of treatment, it probably matters somewhat less what the outcome is in the very first or second line, because ultimately there will be multiple lines of therapy yet to go.